Let's start our first topic today. Our topic is going to be on Chapter 16, Respiratory Emergencies, Pulmonology. So a great introduction to respiratory emergencies is respiratory distress is usually caused by respiratory system problems. Not only respiratory system problems, but other problems involved, such as cardiovascular. Actually, respiratory is probably one of the most common complaints somebody will call 911 for. It's not always respiratory related, it could be something else. You know, I'm having an anxiety attack. What would be their chief complaint? Respiratory difficulties. Nothing cardiac related, nothing respiratory related. Completely 100% emotional. So we're going to learn that respiratory calls and complaints is something common we come in contact with. So respiratory stress is one of the most common EMS dispatches I just mentioned. So something you will be dispatched to quite frequently. And for those who are currently working out in the field, you probably, every other call has some type of form of difficulty breathing tied to the run. All right, as asthma and COP is among the top 10 chronic conditions causing restricted activity. So what does that tell me when they say 10 amongst 10 top issues in the United States? This is a common call we run on. COPD, asthma is a common call we run on. Okay, as pneumonia is one of the most common fatal illnesses developed in our country. And people say, wow, pneumonia, really? Absolutely. And when you go out there, you're going to see, from my experience in dealing with patients with pneumonia, is a lot of times these patients are in severe distress. And when you put pulse oximetry on them, they way low in the 80s. You're like, oh my God, I need to intubate this guy. But they do, I will say, they do respond pretty well to, if their breathing is adequate, to non-rebreather high con O2. And you'll see the stats come up, they start feeling a lot better. But pneumonia is a big killer in our country. It does kill people all the time, okay? So some respiratory diseases we're going to learn are due to genetics. You know, just something that's hereditary. The genetic factor plays a key role. All right, and while others can be caused by external factors, and we're going to talk about that. Asthma specifically. Asthma I like to refer to as not only a restrictive disease, I like to talk about asthma as a trigger disease. And if you embed that into your brain, that when you deal with asthma and you call it a trigger disease, then automatically you know something is triggering this patient on having this attack. So if we don't evaluate the trigger, or we don't remove the trigger, we know it's going to constantly create a chronic asthmatic problem. As an example, I have a patient who has a history of asthma, has an asthma attack, and what's causing his asthma attack is a respiratory infection. So a respiratory infection and his bacteria needs to be treated with antibiotics. So I know until those antibiotics are prescribed and they're taking it and they follow their regimen, it's going to create an asthmatic problem for this patient. So me treating the patient initially with albuterol, Atrovent, or those bronchodilators, it'll fix the problem right then and there because the medication is on board. The problem is when that medication wears off, what's going to happen to this patient? They're going to start having difficulty breathing again. Why? Because the trigger. We never fix the trigger. He has a respiratory infection. So things we got to take into consideration. So I have to prompt and educate that patient that, hey, we still need to go to the hospital because you're going to need antibiotics for the respiratory infection that you have. Until that's corrected, you're going to keep having these events of an asthma attack. And if we don't take care of it today, what's going to happen is there's going to be a worse outcome later if you don't fix it. Does that make sense? Okay? So I like to look at asthma as a trigger disease. So we focus on what's triggering this patient to have this disease right here. So let's talk about, before we get into all these diseases, let's talk about different things we want to focus on that's going to determine adequacy of breathing as well. So let's start with something that's called hypoventilation, which is low ventilatory rate. Okay, so carbon dioxide is going to accumulate in the body with the lungs fail to work properly. So carbon dioxide we know is the bad gas. Carbon dioxide is the waste product. We want to get rid of that. That's bad. When a patient accumulates a lot of CO2, we're going to have an issue. And hypoventilation is a common cause of accumulation of CO2. All right, so CO2 is a combination with water and formed by carbon ions and hydrogen ions bonding together, creating the acid. So water, CO2 bond together, creates the hydrogen ion that creates the acid in that patient's body. So your body's constantly producing the byproduct, CO2, and your body's predominantly made up of water. So that means we're going to constantly have accumulation of hydrogen ions. But how we regulate that, or how does the body regulate that? By its respiratory system. So if I'm hypoventilating, I'm no longer regulating that CO2. I hyperventilate, CO2 builds up. I hyperventilate, I blow off too much CO2. So we have to have normal ventilation. So we need to look at that. So keep in mind, when somebody hyperventilates, the take home here is that I'm going to become acidic. On what level? The respiratory level. Okay? So this is a chart that's actually in your book, but impaired ventilation is caused by various factors. Multiple things can actually make a patient hyperventilate that now their breathing could become inadequate. So you look at this chart here, they break it into 4 different categories, which is, I like this chart. Upper airway obstruction. If I have upper airway obstruction, the next thing is going to be lower airway obstruction, chest wall impairment, and then neuromuscular impairment. So let's talk about those things specifically. So when we talk about upper airway obstruction, we're talking everything above the landmark of the epiglottis or the larynx, right? So we talk about foreign body obstruction. That's pretty simple, pretty obvious, pretty basic. If I have an object obstructing airflow in my upper airway, I'm going to become acidotic. I'm going to become acidic because my breathing is inadequate, okay? It's going to impair my ventilation. Infection, when you have an infection, what happens around that tissue? It swells. Very good. You have inflammation. So inflammation around the glottic opening is not good. So that could impair the patient's ventilation. And then trauma, blunt force trauma to the upper airway, to the neck, can cause impaired ventilation. Okay. Lower airway trauma can be of an issue as well. Patient has, blunt force trauma to the chest, causing severe damage to the alveoli, maybe a pneumothorax or something to that effect, which we'll talk about later on. All right, obstructive disease. Obstructive disease. Now, there's 2 types of obstructive disease we're going to refer to. One is called the chronic obstructive disease. And when we use that word chronic, we mean all the time. So such as COPD, right? COPD stands for chronic obstructive pulmonary disease. So when you're diagnosed and you have chronic obstructive pulmonary disease, that means you have a disease that's going to obstruct your pulmonary system 24/7. So with patients with COPD, because they have obstructive disease, they're always going to be short of breath. And we're going to learn that in the next couple of weeks, that COPD is always going to be short of breath. So we don't respond to a COPD patient's house for shortness of breath. We respond to their house for an exacerbation of their shortness of breath, meaning today is different than every other day that I'm short of breath. So we can't walk in with blinders on or have tunnel vision and say, oh my God, they're in distress. No, it's more of, okay, I understand you're normally in distress, but what's different today than yesterday? Or what's different today than last week? Why are we here? And they'll explain that to you. Well, what's different is I normally could sit down, relax, I get my breath, I can function, but today I feel like I can't catch my breath and I haven't done nothing to exert myself. So that's a difference. So it's an exacerbation of their COPD. Now we have another, that's a chronic obstructive disease. Now we have relative or restrictive disease, such as asthma. And why is asthma not categorized as a chronic obstructive disease? Many years ago, they used to classify asthma as a chronic obstructive disease. And why it's not? Because I could treat an asthma patient, make them feel better, remove the trigger, and they live a normal life. Until when? And then they walk around and they have no difficulty breathing, they're perfectly fine, until something triggers it again. So it's not a chronic disease. They're not short of breath 24/7. They're only having difficulty upon the attack of asthma, and something has triggered it, okay? So both of those, what we refer to obstructive disease, one being chronic, one being relative. All right, increased mucus production, that can fall under both. It can fall under asthma because they have some mucus inflammation, and chronic disease as well. Chronic bronchitis has an excessive amount of mucus plugging. So that could be of an issue as well. And then airway swelling to the lower airways. We have edema that builds up, constrict the smaller airways, the bronchioles. or maybe inhale of toxic substance can cause inflammation as well, okay? So edema is huge, or just straight pulmonary edema coming from the circulatory system into the lungs. That's edema as well. Then we go to chest wall impairment. Now we're impairing the wall's ability or the lungs' ability to expand. So they have a pneumothorax. And let me tell you about pneumothoraxes. And we're going to learn this more when we get into trauma. And I'm going to emphasize this. And I'm going to really stress pneumothorax. Nobody dies from a pneumothorax. Nobody. People die from a tension pneumothorax. Why do I mention that? Because we are scared to put a needle in the chest because we're scared that we might cause a pneumo if he doesn't have a pneumothorax. But I want you to know that people don't die from a pneumo. So if you puncture the chest and you pop the lung, they're not going to die. Yes, you might have created a pneumo, but they're not going to die from that. But if the patient had a tension pneumo and you was hesitant to pop that chest, that's what's going to kill them. So we're going to learn how to assess and quickly identify a pneumo. We're going to learn how to assess and quickly identify a tension pneumo. But I would tell you, when we go through scenarios and we're at the part where we're learning about pneumos and the patient is presenting to you with a tension pneumo and you don't pop a chest, you will fail because you have failed to provide the patient with critical care. That is critical care. So I don't want you to be scared to pop a chest. If you say, wow, I have asymmetrical chest rise, lung sounds are absent or diminished on the right side, and I have a mechanism of injury that's telling me that there might be a pneumo, then guess what I want to do? And it's tension. I'm going to pop it. I'm going to stick a needle into the chest. Done. And if you were wrong and you pop the lung, he has a pneumo now. Is he going to die? No. He will die of his tension, because that tension pneumos will put pressure against the heart and allow it to contract, okay? So we're gonna talk a lot more, but I'm not saying, I want to be real clear, I'm not saying just go around, pop chests, put a needle in everybody's chest. What I'm saying is know how to identify what a tension pneumo is so we know what the definitive care is going to be, okay? Flail chest. Flail chest is a big one. What's a flail chest? 2 or more ribs broken on both sides. And we're going to cover a lot of that when we get into our, after midterm, when we get into our, or later on in the program when we get into our trauma lectures. But a flail chest is 2 or more ribs are broken on both sides. So why is this here in respiratory chapter? Because it will compromise respiratory. It will create the patient to hypoventilate. Patients with flail chest will hypoventilate. Why? A flail chest hurts. And when I'm inhaling, I'm about to expand my chest, I'm going to have those pain receptors start sending signals to the brain to stop breathing or to stop taking a deep breath because of the severe pain. So their breathing becomes very shallow and very slow. So they're going to show signs of hypoventilation. So most people, if you talk about them, I'm going to be a stickler with this as well when we get into trauma, is how we manage a flail chest by adequately assessing the patient's breathing and airway. That's what we do. There's no Boki dressing we put on. There's no sandbags we put on the chest. We don't do that. Doing that and restricting that flail segment can actually hinder the patient's ability to breathe. Not only that, we risk popping the lung. How many broken bones you know break nice and smooth? None. They're rigid. Now I'm going to take this heavy Boki dressing, put pressure on that flow segment, so when I do take a deep breath, my lung is going to expand and rub against that broken bone and possibly what? Pop it. Okay? So the proper way of managing a flail segment or a flail chest is by adequately assessing and managing their breathing. Because these people with flail chests most likely might quickly go, their breathing might quickly become inadequate because they can't take a full deep breath. They're going to hypoventilate, so I might have to take over and ventilate. Now, if I take over and ventilate, I got to pay attention to what's that flail segment doing because I don't want to pop the lung. Okay, make sense? So we're going to give enough air to do what? Chest rise.
If we're manually ventilating, and since that's positive pressure, will we still have paradoxical movement?
Yeah, absolutely. And paradoxical movement, it's not something that, oh my God, I got paradoxical movement is bad. No. What's worse than that is patient not breathing adequate. So if I'm ventilating, it's creating paradoxical movement, so let it be. My thing is what? Is my ventilation adequate? Am I adequately ventilating my patient? Yes, then we're golden, we're good. But we're going to pay close attention to that flail segment because we know what that flail segment can do to the lung. Make sense? Okay? All right. So pleural infusion, all right, pleural infusion is just an accumulation of a little bit of fluid in the lung system, all right, in the pulmonary or in the chest cavity, all right. Infusion will always be a little bit, as a tamponade would always be a lot, okay. So that's what that is. And then we got restrictive diseases, and we're going to talk about that later on, okay. And then we have neuromuscular, which we're going to talk about later on as well, but overdose falls under. Why does overdose fall under a neuromuscular impairment? Because who sends the signal to the diaphragm to contract and relax? The brain. Very good. Central nervous system. Is that neurological? Is that via a neurotransmitter? Absolutely. So the brain sends it. But if I sedate the brain with narcotics or a sedative, the brain can't respond appropriately. So people who overdose on opioids and stuff like that or sedatives, they're going to have some neuromuscular impairment. The diaphragm is not contracting adequately or properly. They're going to start to hypoventilate. Why? Because the brain is feeling the effects of this overdose of this medication, especially like heroin and those type of opioids and sedatives. So we have to manually make sure that diaphragm contracts, okay? And then the other ones we're going to talk about as well, the Lou Gehrig's, and we're going to talk about some other, not only just Lou Gehrig's, we got Guillain-Barré. We got a bunch of other neurological diseases we're going to talk about when we get into neurology that actually impairs the diaphragm, because all those neurological diseases affect the neural pathway that goes from the brain to the diaphragm to contract. All right, Lou Gehrig's is one. It impairs the ability for the pathway from the brain to the muscle. And when we lose that communication, then the diaphragm can't contract, and then their breathing becomes inadequate. And like I said, we're going to talk a lot more about those when we get into neurology. But keep in mind that they could impair neuromuscular issues. They can create neuromuscular issues. Carbon dioxide, it's another one. And what I want you to understand is when a patient is severely acidic, you know what happens to oxygen on the hemoglobin? It falls off of it before it makes it to its target tissue. So I could adequately ventilate a patient or think I'm adequately ventilating a patient, but because my patient is so acidic, the oxygen falls off the hemoglobin before it makes it to its target organ. So am I accomplishing my mission by getting that tissue all the oxygen it needs? No. So that's how acidosis can impair the flow of oxygen to tissues because of being so acidic. That becomes of the issue. Does that make sense? Everybody with me on that? Okay. So very important. We're gonna touch on all these, not just today, not tomorrow, but the whole entire program, because we talked about different types of diseases and issues that create respiratory problems or inadequacy of breathing. So we got to make sure we constantly go back and visit these other chapters. All right. I'll give you an example. Yesterday, I was playing the card game with my guys yesterday, and there were some questions. They were like, "That's not in my book." And I said, "Well, did you visit chapter 7? Take a look there." Or went to chapter 7 and looked at endocrinology. The answers were there verbatim. So you have to go back and visit those other chapters. All right. So if I'm talking about respiratory today, we're going to go back to chapter 7. And we're going to go read the respiratory part of chapter 7 so I have a clear understanding about anatomy, physiology, and pathophysiology. All right, so some other stuff that creates hypoventilation, carbon dioxide levels, is directly related to pH, as we know, right? That's going to shift my pH balance to the right versus the left. So hyperventilating a patient usually has respiratory alkalosis. Because what I'm doing if I'm hyperventilating, blowing off CO2. And when you blow off CO2, I become more alkalytic versus acidic. If I hypoventilate my patient, then my patient becomes respiratory acidotic. All right, so it becomes more acidic because we're not blowing off enough. Okay? So what's going to help us prevent us from doing either one of those when it doesn't permit it? What do we have in our our arsenal of tools that we could utilize to help manage the balance of that acidosis versus alkalosis? Capnography, end-tidal CO2, absolutely. I tell my EMT or whoever's on ventilation all the time, it is the gospel for me to say, hey, see this monitor? Can you see it from where you at? Yes. Look at this number. This is the number I want. This is the ventilation I'm looking for. Okay? So if I had a head trauma patient with signs of herniation, I want my number to be between 30 and 35. So I'm going to tell them, I want you to have controlled hyperventilation because I'm showing signs of herniation. We're going to learn about that later. And I'm going to say, I want you to look at that. This is going to tell you how fast you ventilate because it gives you a respiratory rate, and it's going to tell me my end-tidal CO2. Make sure the end-tidal CO2 number is between 30 and 35 for me. If you find it that is going low, it's around 25, what are they doing? They're hyperventilating too much. So what do they need to do? Slow down. If I see that number is climbing, 60, 50, then I'm not hyperventilating enough. So in that case of a head trauma or intracranial pressure, I need to hyperventilate, but I need it controlled. We just can't uncontrolledly ventilate quickly. We have to control it. And then when I have a cardiac arrest, I tell them, hey, I would like my number to be between 35 and 45. But what I want you to focus on that's more important is how fast you're ventilating. So you see that number right there? I want you to keep it from between 6 and 8 breaths per minute. You see 20, you're going too fast. All right? So I want you to maintain that. So those are good things. That's a great tool we have that can prevent us from, one, over hyperventilating when it doesn't need it, or two, under ventilating when it doesn't need it. We talked about some basic stuff, but these are some other diseases that can actually can impair lung function. Anytime you impair lung function, we're going to have inadequacy of exchange of gases. So if I have an inadequacy of exchange of gases, we're talking about a problem with respiration, right? Because if I have impaired function of physical movement of diaphragm, we're talking a problem with ventilation. Physical movement, always ventilation. Respiration, we're talking the exchange of gases. All right? So, electrolysis is something that we see we see the alveoli collapse for a reason. So, what's a common thing that can happen? Maybe a kid who's born prematurely, before his last maybe 4 weeks or less than 36 weeks, they might have this issue because they lack surfactant. And yeah, that's going to keep the alveoli open. So that process is when the alveoli open and then they close when you exhale. Should they be going flat? No, alveoli should maintain their integrity. If they're going flat, then that's the problem we have there, okay? Next one we're going to talk a lot more about, okay? Pneumonia is huge because pneumonia could quickly become inadequate. People die from pneumonia, and that's what we need to understand. So if we're taking a pneumonia patient very lightly, and we're not being aggressive with them, they could end up dying in your arms. So we're going to talk a lot more about pneumonia. Pulmonary edema is here in respiratory, but it's a cardiac problem. Pulmonary edema is a cardiac problem that creates a respiratory problem, or a cardiac issue that creates a respiratory problem. So it's the heart's failing to pump. And when the heart fails to pump, fluid backs up. And we know that the left side of the heart gets its blood from the lungs. So if I'm failing to pump on my left side, it is backing up into my lungs. Now that pulmonary edema is filling up my lungs, because that's what pulmonary edema means, right? Fluid in the lungs. So what's that going to impair? Ventilation or respiration? Respiration, very good. So we're going to now have problems with the exchange of gases. We're going to have problems exchanging CO2 and O2. So tell me some problems we're going to have with that, with the exchange of two gases. I'll give you one, and you give me some other ones. He's going to become hypoxic. Why? CO2 can't pass through. What's some other issues we're going to have? He's going to be acidic because what can't come out? CO2 can't come out. And when CO2 can't come out, the patient is going to become acidic. And what did I just tell you, when the body is severely acidic, what's going to happen to the oxygen that's in the system, in the hemoglobin, going to an organ and end up doing? Falls off. So we have a double whammy, okay? So I want to talk quickly what goes on, and I think I talked about this with you guys when we did airway, but I'll go over it again. All right, so what we have here is a bronchiole and an alveoli, just in case you don't know what my picture looks like, or a piece of broccoli, whatever. All right, so what's surrounding the alveoli? Our surfactant is all in the alveoli, but what's around it? We have capillaries. Very good. Thank you so much. And I'm going to just do this so we can distinguish that this is the capillary, this is the circulatory system. All right, inside the squiggly line. So we have the alveoli, we have the interstitial space, and then we have the circulatory system. Everybody understand that? So we know what's coming in? O2. We know what's coming out? CO2. Everybody with me? We know that this process, which we refer to as respiration, which is the exchange of these two gases, is passive. So does it require energy for O2 to go in, CO2 to come out? No. So how does this take place if it's passive? Well, the alveoli has to completely expand. So I have to take a good, adequate deep breath so this alveoli could expand, because when this alveoli expands, what happens to this membrane? It becomes thin. It becomes so thin that guess what can move freely? Oxygen and CO2. So that means oxygen can enter into the circulatory system. And it means that CO2 can come out of the circulatory system. As long as that alveoli is one, super thin, and that there's no obstructions in between all this. That there's not an obstruction in the alveoli, that the membrane could thin out. There's not an obstruction in interstitial space, and that there's good enough pressure in the circulatory space. So if I have that, then we're good. But what happens with pulmonary edema is fluid, the pressure is so high in the circulatory system, it starts to fill up the interstitial space with water. What is water now? A barrier. Then it could be worse, it could fill up in the alveoli. So my alveoli is expanding. I see chest wall rise. But the problem is the O2 cannot go in because of this barrier. And if he can't come in, who can't come out? Because there's a barrier, because they're not forced. They have no energy behind them to push it out or push it in. It's passive. We created a block by pulmonary edema filling up that lungs, filling up that interstitial space. So now we have an issue. So the only way to fix this, meaning allow O2 to go in, CO2 go out, is what? Remove the barrier. What's the barrier? The water. So how we remove the water? We'll make the pressure greater in the alveoli than in the circulatory system. Because when the pressure is greater in the alveoli than the circulatory system, it's kind of, we're making respiration an active process. So I take that out by making the pressure here, pushes the water back in. Now we have no barrier. Now what can flow freely? Oxygen and CO2. So that's the big problem with pulmonary edema. Is everybody with me on that? Okay, so we understand that on the cellular level what's taking place. Asthma, another disease, by the way, that happens with pneumonia too. Because where we have a whole bunch of junk, it's not water, but we have a lot of congestion surrounding the walls of the alveoli. So it's thickening the wall. So once again, we can't have gas exchange as well. No, why would we do that? That's a good question.
It's not going to go into the...
Well, it's right. It's thick mucus. It's not water. It's not going to go in. It could, but is that a good thing to do? Let's move infection into the blood system. If I move the infection to the blood system, where's that infection going? Everything. So now we end up with a systemic infection. Is that good? No. Okay? Good point. Good. I'm glad you brought that up. All right, asthma. Asthma, we know asthma is a restrictive disease. It's not a chronic disease. What happens with asthma? And it's a trigger disease. A lot of times, the bronchioles is the problem. The bronchioles tend to spaz out, not allowing exchange of gases as well. So it's normally the bronchioles, the terminal bronchioles, where you'll see this issue. So if I cause a spasm or restrict the bronchioles, which is already small enough, then yeah, I can't exchange gases neither. All right, so how we fix that? We got to open up that bronchiole or relax the spasm. If we can relax the spasm, O2, CO2 can go in. And chronic obstructive disease, we have two types. Anybody know the two types of chronic obstructive pulmonary disease? Chronic bronchitis. Keyword, chronic. Chronic means all the time. What's the other one? Emphysema. Chronic bronchitis and emphysema. Those are the two COPD diseases that we're going to deal with. Okay? So what's the difference between the two? Well, COPD, let's talk about that one, is severe inflammation. Severe mucus plugging. What am I doing to all the alveoli? Obstructing it, making that membrane, because that mucus is going to stick to the wall of the alveoli, making that wall thick. So what they're going to struggle with? Respiration, the exchange of gases. So I can't get air in, right? That means if I can't get air in, I can't get what out? So if I can't get air in, what color will you think this patient would be? Blue. If I can't get CO2, what makes up that hydrogen ion? That's what you're really getting rid of, the hydrogen ion. What makes up hydrogen ion? CO2 and what? So I'm maintaining water and CO2. So I become not only acidic, but I'm also maintaining fluid. That's why we call chronic bronchitis the blue bloaters. They're maintaining water and they're blue. Okay? Because they got a lot of mucus, excessive mucus plugging. How you think the body's trying to fix that? They're going to be constantly doing what? Coughing. Trying to do what to this mucus? Get rid of it. But it's excessive. When they get rid of some, it gets replaced with more. Okay? So it's a bad disease. And it's chronic. So they're going to have that until they die. Or you have what's called emphysema. That's your alveoli. So you lost the elasticity of the alveoli. You lost that ability for it to expand. It's just... So the problem is not getting the O2 in. They could get that in because the diaphragm is kind of pulling down and gets the air in. The problem is getting what? The CO2 out is the problem. Very good. That's the problem. Can't happen. And can't get excessive air out. So these patients are trying to, how the body compensates to get this CO2 out, because I got to build negative pressure to get things out, is they start pursed lip breathing. That's how they breathe. Why are they doing that? To build that negative pressure to get it out. But do they get it all out? No. So they have a lot more air than most people. So how does the body accommodate that excessive air? No. How they accommodate the air in the chest wall? They become barrel-chested. Barrel-chested. Because the body's making room for excessive air. Because it's not going nowhere. All right? So those are the two obstructive diseases we're going to deal with. All right? Some other causes of hypoventilation. Conditions that impairs the mechanism of breathing. All right? So now we're talking about impairs the mechanism, the mechanics. We're talking what now? Physical movement of the diaphragm. Physical movement of the diaphragm. So we just talked about diseases that are going to impair respiration, right? The exchange of gases. Now we're talking about diseases that's going to impale the ability for the diaphragm to move up and down. So now we're talking what? ventilation. Ventilation. So I already know when I impair ventilation, there's only one fix we can do for that is what? Key word is impaired ventilation. Ventilation is a key word. So how we fix that? Manual ventilation, or artificially ventilate. If the diaphragm can't move, what do we got to do? Move it for it. We have to physically move it. So I already know these are easy. Anything that's going to impair ventilation, I got to move that diaphragm because it's not going to be adequate. If that diaphragm don't move, breathing is not adequate. Make sense? So we have high cervical fracture. Well, why the hell that's in there? How does a high cervical fracture impede ventilation? Well, it's not. Medulla's above it.
Yeah, your brainstem.
Well, so what you would say? I'm going to hold on. Brainstem, I'll come back to that one. You got an answer? No? Anybody else?
It would be a neuromuscular impairment, the fact that you're cutting off the neurotransmitter.
There you go. That's what I'm looking. Yes, it comes from the brainstem, which is the medulla, but we're sitting kind of above the cervical. Anyway, the brainstem's above the cervical. But we have our nerve pathways that come through the cervical area. And we're talking C345 specifically. Is C345 is your what? What nerve is that? They intertwine together. So when nerves, remember I think I talked about that with you guys? When nerves intertwine, we call those nerves what? A plexus. So that's the phrenic plexus. That's why I say C345 keeps the diaphragm alive. So who's responsible for that diaphragm to contract? The brain is, but how does he communicate that signal to the diaphragm? Via the phrenic nerve. Without that phrenic nerve, guess what the diaphragm cannot do? Contract. And that sits where? There you go. C3, C4, C5. So that's why cervical is there. Is 3, 4, 5 high in the cervical? Yeah. It's up here. If everybody lean forward and you feel that big knot right there is your C7. That's C7. It's a great landmark, C7. So we're talking above that. That's high up in the neck. So fracture there, you're going to have issues. This is going to impede on the diaphragm, okay? Now it says C345. How about if I have a fracture up at C1, C2? Will that affect it as well? Anything above it? Absolutely, okay? Flail chest, we kind of talked about that, right? Flail chest, 2 more ribs broken on both sides. What's the diaphragm not going to do? It's not going to want to contract because of the pain. So the adequate chest rise becomes impaired. It becomes inadequate, okay? Severe retraction. I'm retracted. Why I'm severely retracted? Because I can't get air in. So diaphragm can't move adequately. Diaphragm is struggling. All right? Air and blood filled in the abdomen. If my abdomen is severely distended, whether it's air or blood, my diaphragm can't what? Contract. He has nowhere to go. Has nowhere to go. You know where that's common at? In kids. So we got to pay attention. In little kids, especially small pediatrics, if I'm ventilating and I got a big distended abdomen from air, guess what the diaphragm is not going to do? Contract. It's going to impair the diaphragm from contracting. Obesity, hyperventilation syndrome, obesity, especially laid down, all that weight is on where? On the diaphragm. So guess what the diaphragm can't do? Contract. So guys, what does all of these have in common? Diaphragm contraction. All those does not allow the diaphragm to contract adequately. So this is an easy fix. I already know this problem right here, I can fix it if I do what? Ventilate and make sure the ventilation is adequate. We got to make sure it's adequate because we have the tendency to put a BVM on the face and squeeze a bag, and we think 100%. If I put that mask on the face and I squeeze that bag, everything's fixed. No, you got to make sure, are we adequately chest rising the patient? Do we have adequate chest rise? If not, what we do? Continue. We find an alternative method. So we got to figure, hey, do we put a supraglottic in? do I intubate this patient? What am I going to do to make breathing adequate? Done. Because if I don't have chest rise and that BVM is not working for me, then I got to consider an alternative. No ifs, ands, buts about it. Make sense? Okay? So that's the easy one, right? Because we know they all impair the diaphragm. Now, because my diaphragm is impaired, can that create a problem, a domino effect? Now I have respiratory issues with the exchange of gases? Absolutely. But I know I can fix it if I just do what? Adequately ventilate. So if I had a ventilation problem and it's inadequate, will my patient become acidic? If my diaphragm is not adequately contracting, will the patient become acidic? Yeah. So do I panic and give a sodium bicarb, a drug that's going to neutralize the acid? Or what can I do? Adequately ventilation. If I adequately ventilate, do I fix that? But because he had a buildup of accumulation of acid, I expect initially, when I ventilate adequately, that what comes out is highly concentrated, right? We expect that to be highly concentrated until we get a couple of good ventilations in there where we're blowing off all that excessive CO2 that they couldn't get rid of. Then now they're getting rid of it. And if I have a high CO2, so if I had this patient that I recognize he had a big problem with that diaphragm, that diaphragm wasn't contracting for whatever reason. Now I have adequate ventilations. I had to intubate to get adequate ventilations. I did so. I put a capnography in. Now I got capnography. What do I expect that number to be initially? Low or high? What you said? High. So am I going to panic initially? No, what I'm saying is, woo, it's high. I expect that. But you know what that high is telling me now? Because of my ventilation, I'm able to get rid of a lot of CO2. And then I'm going to get rid of it. And then what should start happening to that number as we start to adequately ventilate our patient? Start to decrease. And if I keep my rate where it needs to be, a normal rate, then if I have a normal rate, what should be my end-tidal CO2? Normal as well. All right, make sense? All right, so some other stuff, conditions that impair neuromuscular. All right, so we kind of talked about this a little bit, but neuromuscular, so head trauma. Why? Head trauma. Anytime you put pressure on the head, first of all, we're going to talk a lot about this when we get into trauma, but head trauma, first of all, the brain sits in the cranium perfectly. You know how much available real estate is in the brain? In the cranium, I should say? Zero. Zero. Not much is still a lot. Zero. Why do you think we have zero movement, zero space available? Very good. What are we constantly doing with our head? Moving it. So if I had available space in there, what I'm going to do to my brain? I'm going to be hitting, I'm going to injure it. As soon as you turn your head to the right, boom, you got a head injury. So you turn to the left, another head injury. You came back this way, you just multiple head injuries, right? So it's a perfect fit. So we can move our head that's on the swivel without creating brain damage. Make sense? And when you go to an autopsy and they take that cranial, you're going to hear it's going to, it pops. Why? Perfect fit. I don't understand neither. This is the biggest thing that I wish I knew the answer to. But I don't know. Every time I send a student to the MEs, one. If it's in a group, it's always one. When they hear that pop, go out. Unresponsive. Pass out. I don't know what it is about that popping sound, but really, I don't know. So there can't be no room. So knowing that there's no room, and I have an insult to the brain, somebody hit me with a bat, boom, right to the cranium, we already know I have insult to the brain. What's the first phase of healing? Swelling, inflammation. So now I'm having inflammation in the brain. How much available real estate do we have up there? So where's it going is the question. Where is that inflammation going? What's it doing? It's putting pressure against the brain. So we're going to have an increase into cranial pressure. And that's going to create abnormal respirations. Okay? So. And where would we assess the different breathing patterns in our assessment? When you want to assess for different breathing patterns like Chandler-Stokes or Biots or neurological hyperventilation, where in your assessment does that fall in? During the ABCs. Everybody agree with that? I'm going to say absolutely not. No, but most people will say that. That's fantastic. I thank you. I appreciate you saying that because it creates a teaching moment for me. We assess that in our secondary. Because you know what we assess in our primary? If he's breathing adequate versus inadequate. I don't care what breathing pattern I see in my primary. I care, is he breathing? And is it adequate? Because what's going to kill him immediately? The pattern or the adequacy? Adequacy. So I determine, whoa, his breathing is adequate. Perfect. But it's rapid. I need some, maybe give him supplement. But when I get to my secondary, I want to know what type of breathing pattern that is so I can identify where we at with the issue, with the insult. Does that make sense? Okay? Very good. And this is important stuff because when we get into our testing and we get into our national registry, they can get you with that, right? They'd be like, where will you assess different breathing patterns? Well, I know I shouldn't do that initially. I should be worrying about is it breathing adequate or not. So where is it going to fall into? My secondary. All right, so infection to the brain and the cranium, because what does infection create? Swelling as well. All right, brain tumors. Does that take up physical space? Once again, intracranial pressure. So that's what that all has in common. All right, spinal cord injury. Why? Especially high up in the cervical. That deals with the breathing. All right, Guillain-Barré syndrome. Guillain-Barré is caused, it's an autoimmune disease. And what happens is for some reason, somehow, some way, your immune system looks at your neurological nerve pathway as a foreign body. So if he recognizes your neural pathway as a foreign body, guess what he's going to do? He's going to attack it. He's going to attack it and do what to it? Kill it. He's going to kill it. Unfortunately, that's what happens. They say Guillain-Barré can be caused, it's normally caused by infection. Because infection, what is he doing? What's your immune system going to do? Try to kill it. But what happens with Guillain-Barré is he recognizes you had an infection, your immune system is trying to kill it, he just don't know friend from foe, or whatever they call that, you know, from good from bad. He's going to that area, and guess what he's doing? He's killing it all. We're dropping the napalm bomb right there. Boom, we're killing everything. That's what it does. So that's when you develop Guillain-Barré. They do say you can catch Guillain-Barré through vaccinations, but they say it's less than 1%. So, very rare. Somebody must have developed Guillain-Barré after giving like the flu shot or something to that effect. So, since then, they say you could. But, very rare. Everybody with me on that? We're going to talk more about Guillain-Barré later on in neurology. Yes? Once you have it, it's autoimmune.
So how long does it take to the person to deteriorate?
Guillain-Barré, it's not as going to die because it attacks just that area of infection. Well, of that area of infection. Yeah. Okay. So there's other worse neurological disease. So, but it's not too bad to be managed. Okay. You don't really hear too many people dying from Guillain-Barré. Now, Lou Gehrig's disease, ALS, different ball game. Now, like I said, we're going to talk a lot more about these neurological diseases in neurology. But we got two types of neurological diseases. Diseases that attack the sensory pathway. That's the pathway from the body to the brain. That's one. And then we have neurological diseases that attack the pathway from the brain to the muscle, what we call a muscular or motor pathway. Lou Gehrig's ALS attacks the muscular motor pathway. So whatever the brain's sending out via that pathway, that's what's attacking. All right? So, and unfortunately, it attacks quite quickly the pathway to the diaphragm. So if I destroy the pathway from the brain to the diaphragm, what can the diaphragm not do now? Contract. That's the killer, Lou Gehrig's. I got a good friend of mine who grew up in high school, went to high school together, and elementary school together. He was recently diagnosed with Lou Gehrig's last August. And last August he was diagnosed. He has to wear a C-collar. Why he has to wear a C-collar? Right? Because what does Lou Gehrig's attack? The motor sensory that goes to the muscles. So if disrupt that electrical conductive pathway to that muscle, then the contraction of the neck or that muscle can't function properly. So you get rid of C collar. And he's in a wheelchair now. Why? Muscles. Eventually, it's going to affect his diaphragm. There's no cure, so he knows. They say in the average 2 to probably 4 years.
You were at an event, I had a patient last week.
Yeah, you end up going to an event.
The
Yep.
guy was fully alert and oriented, could understand everything you were saying, so he couldn't speak when he was on event though.
Yeah, because it attacked his diaphragm. Now he can't contract. So what the vent does, breathe pushes that diaphragm down for you.
So
So
you can extend your time on that, but
yeah.
that would suck.
Yeah, you extend your time, but eventually, all your muscles, your whole motor pathway is gone. So you can't do nothing. So they said about 2 to 6 years, you know,
Because the heart has
automaticity.
automaticity, it wouldn't affect that, would it?
No, it's only that brain to its neural pathways, muscular pathway. Good question. Okay, so Lou Gehrig's is there's no cure for that. It's not. They call those autoimmune disease.
What about, would it affect like your GI tract and all that?
Yeah, absolutely, absolutely,
So.
absolutely. Can't
that
bowels.
would kill him too, because
Yep.
you back up.
Back up can produce. You can't control uncontrolled bowel movement. So it affects all your organ systems. It affects everything. So and there's no cure for that. That's the bad part. And it just beats you up. It beats you up, kills your neural pathway. And they call it autoimmune. And then obviously, botulinum diseases, bacterial disease that eats up your neural pathway. Now, you're going to learn a lot of these neurological diseases. We're going to talk about neurology. They call it, they'll say you have an autoimmune deficiency. And that's why you have this disease. And you'll see they say autoimmune deficiency. Why? Because we know one thing for certain. Automatically, your immune system is doing what? Attacking his body, attacking itself. The question is why, right? We don't know. That's why they call it autoimmune disease. All we know is that automatically the immune system kills you, and that's a disease of that process. Because we don't know how and why, it's hard to find a cure. So they call it so. And people, sometimes people are so satisfied with that word. Oh, I got an autoimmune disease. What I'm really telling you, if you got a disease and I don't know why, your immune system is killing it. So what can we do? So we're going to talk about MS. All those do the same way. Okay, do the same thing. All right. So some more hyperventilation issues. So we're talking about conditions that are going to reduce respiratory drive, meaning drive you to breathe, is intoxication, because intoxication puts you into a state of sedation. Alcohol is the biggest sedation, one of the biggest ones. Anybody ever drank enough? What's the end product of over drinking? Passing out. Sedated. Okay? Intoxication puts you in sedation. Sometimes so bad, people die from it. You know why? They vomit, but they're so sedated, they aspirate. So they're laying supine, they vomit, goes up. What goes up must come down, and they aspirate. And they die right there. Aspiration of stomach content has a mortality rate of 80% plus. That's a high rate. Okay? So intoxication is bad. Now, not just alcohol, intoxicated with sedatives, intoxicated with opioids. Anything that could put you into a state of sedation, that you overdose, you take more, is a state of intoxication. All right? Toxicity, head injuries. Head injuries will suppress your respiratory drive. Knock out that medulla. Hit that brainstem and see what happens. Okay? That's the medulla is your primary, as the pons is your secondary. But what does the pons and the medulla have in common? They're both in the brainstem. They're both in the brainstem. Knock out that brainstem, you knock out your drive to breathe. Okay? Hypoxic drive. What drives us normally to breathe? High levels of CO2. All right? So hypoxic drive, oxygen, we'll talk about those patients, COPD patients later, that drive off of low levels of O2. Being hypoxic drives them to breathe. So if I have them high levels, then I can suppress it. And now they don't breathe. All right? Asphyxiation is simple itself, right? That's pretty expelled. Strangle somebody, it's going to knock it out. All right? Or vice versa, a significant blow to the chest wall, creating your ventricles and everything to pump backwards, significant, can cause asphyxiation as well. All right, strangling, hanging themselves, stuff like that. Okay. So the ultimate manifestation of respiratory arrest followed by cardiac arrest. Obviously, cardiac arrest we all know that's pretty simple, black and white. I know when they're dead, they're not breathing. All right, you call it hyperventilation, we might call it apnea, right? So we got to initiate aggressive treatment to assist these patients in their respiratory effort. Because if you can't manage the airway and breathing, what does everything else mean? Nothing. Means nothing. If I can't manage airway, if I can't manage breathing, what's the likelihood of your patient surviving? It's not. So we have to focus on that, manage that immediately. Okay? Let's get into hyperventilation, which can be a problem as well. So what we notice so far is we're talking about hypoventilation can create inadequacy. So can hyperventilation. So hyperventilation occurs when people are breathing and excessive by increasing rate and depth of respiration. So the faster they breathe, the more they increase their depth of respiration, the faster they end up breathing. We refer to as hyperventilation. So the problem with hyperventilation is we release more CO2, carbon dioxide, than normal. All right. So we got to maintain the balance. We got to maintain that homeostasis. Okay. So we become in that situation when we release more carbon dioxide than normal, we become respiratory alkalosis. So it's triggered by emotional distress or panic. Hysteria can create hyperventilation, as we all know. All right. Or what we refer to hyperventilation syndrome, which could be a neurological issue. So the problem with neurological hyperventilation, it looks just like the hyperventilation that a person who's panicking can hyperventilate. So an anxiety attack, hyperventilation versus neurological, they look the same. The difference is one has a neurological insult, which is serious, and the other one is just more of an emotional issue that's creating it. So we have to get a good history to determine, is this ventilation secondary from an anxiety attack, or is this hyperventilation secondary from a neurological insult? Okay? So, can cause numbness to the hands and feet and the mouth. Why? Blow off all your CO2. We probably all witnessed somebody doing this, or maybe one of you guys have done this, where you hyperventilate, you're breathing fast, all of a sudden you become very lightheaded. The lightheaded is your brain telling you, hey man, you're breathing a little faster than normal, you're blowing off more CO2 than you need to. But you don't listen, you still hyperventilate. So now you develop these tingling sensation in your hands, your feet. You get some spasms in your hands. They spaz in. It look like this. And at your mouth is numbing up, dries up. And that's your body once again telling you, hey man, we're hitting crucial levels. You're about to hit a level where it's going to be detrimental to maintaining balance. I can't function no more. I can't maintain balance because you're blowing off too much CO2. But then what do? You keep hyperventilating, and then all of a sudden, when you get to that crucial level, boom, the brain knocks you unconscious. Why would the brain knock you unconscious? Because respiration, breathing I should say, it's a volunteer and involunteer process. So you could consciously control your respiratory rate. If I want to breathe fast, I just start breathing fast. If I want to slow down, slow down. And when you're conscious, the central nervous system can't control it. But when you're unconscious, like at night when you're sleeping, who controls breathing at that point? The brain does. So that's involuntary. So the brain knows the only way he could control breathing is by knocking you unconscious. So at that point, when you're hyperventilating, you're hitting crucial levels, knocks you unconscious, he takes over, he starts to hypoventilate. When your CO2 levels get back to normal, guess what happens to the patient? Wakes up and feels slightly better. Okay? So you're going to have those carpal pedal spasms. As I mentioned, your hands be like this, and that's just letting you know once again that you're breathing faster than normal. You're getting rid of more CO2 than need be. So having patients rebreathe carbon dioxide can be dangerous. So back in the days, way back in the days, historically, we used to do that. We'll say, well, if I'm hyperventilating, what are you blowing off? CO2. More CO2 than you need. So we used to give them the paper bag and have them breathe into the paper bag, because what are they breathing back? The CO2, the expired air, but it's only about 1%. You know, but anyway, CO2, we weren't that's fine. You probably would breathe back in CO2. But the issue is, what if it's a neurological hyperventilation and it wasn't psychological hyperventilation? You kill your patient. You kill them. So we'd rather you give a non-rebreather of oxygen than have them rebreathe their air. Why? What's the worst case that happens to a patient who's having a psychological hyperventilation event? They pass out. Who takes over? And they wake up and everything's fine. You gonna kill them? No. Man, maybe they'll pass out sooner with the oxygen, right? But if this was a neurological issue and you get that paper bag, you kill them. And they probably need oxygen. So if you give them a non-rebreather, then we don't kill them. We give them what they need. So you can't hurt the psychological patient by giving them oxygen. But you can hurt the neurological patient by giving them a paper bag. Okay? So the paper bag theory, out the window. We don't do that no more. Okay? Patients quickly exhaust the O2 and the gas that they are breathing. So keep that in mind. Hyperventilation is a patient who's acidic and maybe, as I mentioned, maybe the body's attempt to rise their pH balance. Maybe it's neurological. Maybe it's something going on internally that the body's doing this. So we got to investigate because they do present the same way. So treatment may include for hyperventilation something as taking the edge off. If it's an anxiety issue, a panic attack, you can give them a sedative. Because what's the sedative going to do? Calm them down. Take the edge off. They start breathing a lot better. What I've known, psychological first aid works phenomenal. What I've done, people hyperventilate that I know that this is truly psychological, they have an anxiety attack, whatever it is, I tell them, get a glass of water. Drink some water. And what I do is I give them the water. As they drink, I hold the bottle, and I hold it up for a second or two. All right? I'm not going to keep it there. I want them to aspirate. I mean, we're not waterboarding our patients. All right? So I drink it, because what are they not doing when they're drinking water? Breathing. So now I make them drink water. Drink water. Okay, drink water. I'm controlling their respiratory rate, and they don't realize it because they're not going to breathe while they're drinking, so it starts to slow down. And every time you're drinking, what's going to start to accumulate? CO2. Get it back to normal. Okay. So breathing with the patient helps out. Come on, do it together. Follow me. Come on, deep breath. Okay, let's hold it for a second. Okay, let it out. Go out, and then sometimes distracting them, talking about other things, can take their mind off it. Have the patient count to 2 between breaths. Okay, deep breath. Okay, let it out. Okay, 1, 2. Okay, another deep breath. Let it out. Okay, let's count. 1, 2. And you can move up from there. Distraction techniques, as I said, talk about something else. Get their mind off it. You get their mind off it, you see how you control it. Have the patient sing a song. Then when you get their mind off it, they'll be like, you see, I told you forget about your boyfriend leaving you and you feel better. Oh, it's going to create the anxiety again because you triggered it again. So don't do that. Have a sing a song. Maybe it's kids and stuff. Sing a song. I don't know too many adults will be willing to sit here and let's sing ABCs or something. Let's sing Kumbaya, whatever. It's not going to happen. But kids, it might be. All right, might work. So a little bit of the anatomy. We kind of saw this picture before. We showed you this picture when we were talking about A&P and we talked about airway. So the bronchioles, just keep in mind the alveoli is the lowest part of the respiratory system. That's the end. That's the cul-de-sac. That's where it ends, is the alveoli. Right next is the terminal bronchioles, the main stems, then the main bronchus, the trachea, so on and so forth. So if you think about it, it looks like an upside down tree. Okay? So the upper airway, this is repetitive, guys, of what we just talked about not too long ago in talking airway management. So we know that the upper airway structure is nasal, the nose, right? Air entering into the nostrils is lined with hair. What does the hair act as? A filtration system. So it's going to filtrate the air we breathe in. All right. Quiet breathing quiet breathing allows air to flow through the nose and out. And the key thing is with breathing, should it draw your attention? No. Breathing is effortless, so it should not draw in your attention. If I am hung up on looking at your breathing pattern, then your breathing is probably not where it needs to be, and I need to focus in on why your breathing is drawing my attention. All right. We talked about the nostrils. They have the hairs, filtrates, warms, humidifies, warms the air or cools it down, depending on what we're inhaling. All right, it has many blood vessels, and the blood vessels are there to heat up that air, cool it down, or cool it down. It depends on the situation, right? And this is the structure that we're very familiar with. We talked about it, so it's giving you a visual from the nostrils all the way to the larynx on what we have as far as patient's airway. Just keep in mind we talk about that glottic opening, or that larynx is the separation between upper versus lower. So, this is a good picture right here. It's a phenomenal picture. Mouth and the oral pharynx is an area where it contains blood vessels, mucosa, mucous membrane. All right, edema can be extreme because the tongue could swell up significantly. There's a lot of room in the tongue to swell up. All right, so ask the patient if their tongue feels thick. That's a good indication. Does it feel thick? Or watch how they talk. If they start talking like the tongue is getting in the way, what I want to know, do you normally talk like that? Or is it something new? If it's something new, that means that the tongue might be swelling up, okay? So monitor the patient's speech. So right there, the tongue swollen like that. Do you see any hives on her? So you think this is an anaphylactic reaction? Or allergic reaction? Normally allergic reaction? No. It is a reaction. And when you have the tongue, which we refer to as angioedema, is secondary to an ACE inhibitor, such as lisinopril. All right, these patients could be on lisinopril, be on an ACE inhibitor for a long time, and all of a sudden develop this. And when you have a reaction to an ACE inhibitor, you have only angioedema. That's it. A lot of times they move air, no problem. Where do you think they move in the air? Her mouth is completely shut in the front, 2 nostrils. So you listen. I'll listen to the trachea. Yep, good air. Listen to lung sounds. Oh, moving, great air. Got them on pulse oximetry, 95, 97%. Are we worried about airway compromise yet? No. No highs, blood pressure is good, and normally that's what you do. So the antidote normally is they'll just monitor the patient until the ACE inhibitor wears off, or they'll give them frozen plasma protein because ACE inhibitors can actually deplete plasma protein that causes the edema. Okay. If they worry about losing the airway, they might consider facilitating intubation on these patients in the hospital. So does Benadryl fix this? No. Does Epi fix it? No. All right, so we just monitor the patient. It's plasma protein to be specific. I had a patient like that many years ago. I had a patient where he called 911 because he said it came over with allergic reaction, and he says his speech was funny, and he felt like his tongue was swollen up and it was tingling. So we get these on a bunch of meds and was recently put on antibiotics. So right away I was like, ooh, this might be allergic reaction to an antibiotic like penicillin or something like that. So he took his meds. He says when he took his antibiotic, he wasn't able to put it in his mouth. He couldn't swallow it. So he took it out. So did he ingest the medication? No. And I started thinking, okay, maybe it wasn't the antibiotic. And I said, hey, any new medications? Like, no, it's my regular medication. The only thing new is the antibiotic. Okay. I look at his medication. He's on ACE inhibitor. He's on lisinopril. So I was like, oh, it's a reaction. He goes, but I've been taking lisinopril for a long time. Doesn't matter. But the guy was 87 years old, significant cardiac history, everything. No urticaria, no hives, no swollen, no watery eyes. Blood pressure was actually slightly elevated. Moving good air, lung sounds are clear, sat at 97%. So I was like, let's just take him to the hospital. So we started an IV, put him on non-rebreather. And the time we got to the hospital, the non-rebreather was pushing off his face because he filled the non-rebreather with his tongue. But he was still moving good air. Pressure was good, everything was good. So obviously, if you got a guy come into an ER and he's pushing the non-rebreather off his face with his tongue and swollen like that lady was, you think that's going to draw some attention? All right, so once again, the bronchioles are made out of smooth muscles, the terminal bronchioles, the bronchioles itself. Why is that so important to know? Because we're going to treat that. When those bronchioles are spazzed, we know they're made out of smooth muscle. I can give a smooth muscle relaxer to loosen up those spasms. That's creating the problem of gas exchange, okay? So always remember, the bronchioles are made out of smooth muscle. Gas exchange does take place in the alveoli, as we know. So we know any obstruction in that area can inhibit the ability of the two gas exchange to take place. So deoxygenated blood releases carbon dioxide and is resupplied with the oxygen. That takes place at the alveoli. So it's made up of two types of cells, type 1, type 2. Almost empty is a type 1 and can make new type 1 cells as well. All right? So major function of the alveoli, all right, functions best when it's kept partially inflated. So what's going to keep the alveoli partially inflated? Surfactant. The surfactant that sits around there. Now, surfactant, we get that in the baby gets that in the last trimester of the last 4 weeks of their pregnancy, That's when they get it. But we need it. The problem with surfactant, it can be washed away. Somebody has pulmonary edema, that fluid coming into the alveoli and then going back in and stuff like that can wash away surfactant. So it can destroy the alveoli. It can collapse them. If it fills with pus from like pneumonia, it could also destroy the surfactant, and we have big problems. So now we destroy that surfactant, it doesn't stay partially open. Now we can't have the exchange of gases that we're looking for. All right, pulmonary capillary beds. Pulmonary circulation starts at the right ventricle. Pulmonary capillaries are very narrow. So they're so small that only one red blood cell can pass at a time to off gas. All right. So patients with chronic lung disease and chronic hypoxia often has thick blood. They normally have thick blood. So that's going to increase pressure as well. It's also going to hinder the abilities of the body's ability to exchange gases. But when they start having this thick blood, it increases pressure, circulatory pressure, not only on the systemic side, but on the pulmonary side. And that high pressure from the thick blood and having high pressure on the pulmonary side creates what's called cor pulmonale. Cor pulmonale is due secondary to the high pulmonary pressure, and it destroys the alveoli. Okay? And it destroys the cystoscopy alveoli. So, as you can see in this picture, it's just giving you an adequate diagram of how blood flows and how it picks up oxygen, how it gets rid of CO2. So we know it goes from the right ventricle to the pulmonary system to pick up oxygen, offset the CO2, comes back to the left side to pump it to the body to give it O2 and pick up the CO2, and the process starts all over again. All right, we talked about the interstitial space between the alveoli and the capillary. That space needs to be clear of fluid. If fluid builds up in there, it's going to obstruct the body's ability to exchange gas. All right, conducting airway distribution of the gas, which does not participate in ventilation, we're going to have an issue. So wasted ventilation is what we refer to as dead space, is approximately 1 ml per pound of patient's ideal weight. Dead space, we have to account for dead space. And dead space in the pulmonary system, roughly, I know it says 1 ml per pound. On the adult average is about 150 ml of dead space. So 150 ml that they inhale is going nowhere. It's just occupying dead space. So if I'm squeezing 150 ml of air, how much is hitting the alveoli? None. All right. Look at this, a great picture. They have scoliosis of the spinal column, which is really jacked up. But chest wall, that could be of an issue. Trauma and diseases can obstruct the body's ability to exchange gases, that chest wall expanding. All right, so it can cause restrictive lung disease. Mediastinum, very important, right here, key player. Lateral borders is the lungs. The inferior border is diaphragm, superior border is the angle Louis, right here. This little area is referred to as a mediastinum. Inside there you have all these key players. Any damage or any problems in the mediastinum could be life-threatening because your heart, large vessels, airway, such as your trachea, and other organs like your inferior, superior vena cava all sit in the mediastinum. All right, function of the respiratory system. Function of the respiratory system, process of oxygen takes into the body and distributes to each cell for energy. We need oxygen, we need glucose. With oxygen and glucose, gives us the energy we need for these cells to break down. Carbon dioxide is returned to the lungs, as we talked about, via the circulatory system, so we can exhale it, get rid of that byproduct. Horrible. That's what respiration is. We talked about ventilation. It was the physical movement, the mechanical movement of air in and out of the lungs. That means that the diaphragm has to physically move for ventilation to take place. And if ventilation takes place, then respirations can take place. We can exchange gases. So normal breathing removes enough carbon dioxide to keep acid-base balance. PCO2, PaCO2 should be anywhere from 35 to 45, with the ideal number being 40. And that's millimeters of mercury, okay? We want the ideal number 40, but 35 to 45 is a normal range. Diffusion is the exchange of gases from the alveoli to the blood cell. All right, diffusion into the alveoli cells in and out, or in the cell and out of the other side. Diffusion into the capillary wall out of the other side. So in a nutshell, what it's saying is O2 comes in, CO2 comes out. If we make that process and that process happens, that's diffusion. All right? Some lung disease may make it difficult for oxygen to diffuse into the blood system. Pulmonary edema is a great example. Fluid in the interstitial space, not going to allow oxygen to go in, not going to allow CO2 to come out. All right? Affected diffusion goes from an area of higher concentration to an area of low. So higher concentration of oxygen into the alveoli, then into the blood system. That's how it works. As perfusion, circulatory components of the respiratory system, blood must keep flowing through the pulmonary vessels. A large emboli can block that. So perfusion is bringing oxygen to the target organ and getting its byproduct, which is CO2. So capillary vessels are important. They make that happen, because those capillary vessels, the pulmonary system, is where that exchange can take place. So if I have a big emboli, what's an emboli? A moving clot. It could be blood, it could be air, it could be whatever, but it's a moving clot. It moves and gets stuck in the pulmonary system and blocks all the blood distal to it or proximal to it to come move into the circulatory system. It doesn't happen. It's running a dry pump. So these patients don't do well. They end up dying. Neurological control, we know who controls it. We need to know that the medulla oblongata controls breathing. He is the main controller, the primary controller. At least 4 parts of the brain responsible for unconscious breathing, okay? So there's multiple parts, the medulla, the pons, up by the hypothalamus, all right? Those areas, midbrain, they all work with controlling breathing. We have what's called stretch receptors, and what are those stretch receptors responsible for? Making sure your lungs don't overinflate. When you get to the max where you can't inhale no more, you trigger those stress receptors, the hearing breathing receptors, and those receptors are there to prevent overinflation. Because if you overinflate, what happens to your lung? Kaput. That's what it's there for. We talked about the phrenic nerve. He's responsible for the diaphragm, that movement of the diaphragm. The signal goes through him via the brain. The signal came from the brain, travels to the phrenic nerve to the diaphragm. All right, the thoracic spinal nerves also help out. They intervene or they stimulate the intercostal muscles so they can contract to make the rib cage bigger and better so they can breathe. Cardiovascular regulations, lungs closely linked to the cardiac function. We said that earlier. They are married, they're partners. The circulatory and the respiratory are intertwined. And because they're together, they're roommates, they're married, whatever you want to call them. If I have respiratory problems, eventually I end up cardiac. If I have cardiac, I end up respiratory. All right, heart changes have pulmonary consequences. Cardiac disease create pulmonary disease. Left-sided heart failure progresses faster than the right side, so we're going to have pulmonary issues as well. So left side fails, fluid backs up into the lungs. So a cardiac issue, not creating a pulmonary issue. Mild hypoxia increases in the heart rate. Severe hypoxia increases bradycardia, especially in kids. It's slightly different. In kids, just hypoxia can make them bradycardic almost immediately. They don't go from tachycardia to bradycardic as adults do. We normally become tachycardic and we stay tachycardic for a little bit, then eventually severe hypoxia become bradycardic. So uncorrected hypoxia can trigger lethal cardiac dysrhythmia, like flatline. Various forms of heart failure, fluid balance changes, fluid shifts. Pressure is greater in the circulatory system. When the pressure is super high in the circulatory system, it's looking for somewhere to go. And it's going to enter the pulmonary system. So you develop congested heart failure. So if you have a high pressure and the right side fails to pump, the pressure is high in the pulmonary system, it's going to back into the right side. If the pressure is high in the systemic system, the body is going to back up into the left side. I like to say left side lungs, LL. The left side will back into the lungs. The right side will back up into the body. We're going to spend a lot more time when we get into cardiac about talking about CHFers. All right, muscular control. Body takes air in by negative pressure. Easy way to remember this. This is how I remember this, guys. When I take a deep breath, what does my chest cavity do? Expand. So my chest cavity increases, correct? So what's taking place on the outside is going to be the opposite on the inside. So if my chest wall increases, what happens to the pressure inside? Decreases. When I exhale, my chest wall decreases, the pressure increases. All right, it's going to increase until the atmosphere pressure is the same as the pressure in my lungs. All right? All right. The thoracic cavity is an airtight box, airtight system, with a diaphragm at the bottom and the trachea at the top. All right? So the diaphragm flattens during quiet breathing, meaning goes down, contracts. Air is sucked in because my diaphragm is going down, it's pulling the lungs. It's pulling the lungs, it's bringing in air, negative pressure. Okay? Minute volume, we talked about this in respiratory, but minute volume can be increased by the depth of breathing and the rapid or the rate of breathing. The faster you breathe, the deeper you breathe, the more you take in, then a minute volume will change. Accessory muscles cause dramatic pressure changes when greater amount of air must be moved. So we use accessories like the abdominal muscles, neck muscles to help in assisting in adequacy of breathing when a patient is in distress. All right? A traumatic opening to thoracic, when we talk about thoracic, it's a clear box, sealed box or sealed cavity. But once you have a traumatic opening, it'll provide a route for air to suck into. So as the diaphragm pulls down, it's pulling the lungs down. I have a hole in the lung in the chest, so it's going to suck in the air from my hole as well as my mouth. So I get twice as much air. All right? And it creates that sucking chest wound. So what we got to do is constantly make sure we cover it all the time. And once you cover an entrance, you should be looking for an exit. Okay? Kidneys play a role in part of controlling because of the fluid balance, acid-base balance. Not only the respiratory gets rid of excessive acid, but so does the renal system. The kidney systems do the same. So they maintain pressure, they maintain fluids, they maintain acid balance. So respiratory assessment includes much more than just listening to the patient's lungs. But we have to listen to lungs. We got to hear, what are we listening to? What sound do we hear? All right, but it's more than just that. Many respiratory elements, all right, or alignments are life-threatening. All right, so a lot of these elements that we read, a lot of these things that are taking place can be life-threatening. So respiratory assessment should be done when? As soon as we can. All right, so we got to size up our scene. This is what we're going to practice this afternoon. I really want to focus in on assessment of a respiratory patient. That's all we're going to focus on this afternoon is how can we adequately, quickly assess these patients. The key is we got to be quick about it as well, but we got to know what we're doing. We're not just hitting check marks. All right, I said this, I said that, I said this, I said that. It's about why did I assess this? What's the reason behind it? What feedback is that going to give me so I know how to move on? All right, standard precaution. I don't think I need to really harp onto that. We know we got to wear gloves. We got to protect ourselves. Now, gloves at the minimum. When we talk about respiratory patients, we got to think about a respirator or a mask or something to that effect. You know, you never see it out there. Nobody does it. Very rarely. A few do, but not too many. When we give nebulized treatments. Who normally gets nebulized treatments? As a patient, right? What did I tell you earlier about asthma? It's a what kind of disease? Trigger disease, right? What's something that could trigger the asthma? Huh? Could be an infection. Is infectious contagious? Can it be contagious? Yes. So when they have an asthma attack that's triggered by a respiratory infection, we give them what? Albuterol, right? So that medication is humidified, sort of, right, through a nebulizer. When they exhale, they coming out in that nebulized air, and that actually lingers a lot longer in the air than if somebody just exhaling. So they exhaling through this port, right, through the nebulizer, and we're sitting there doing what? Sucking it in. So when you do give a nebulizer, what you should wear is what? A mask. But do we do that? No.
Do you wear a mask when you do it?
No, I tell you, I rarely do, rarely do. But I don't transport on a rescue. I'm not in a confined space. But when you're in the back of that rescue, you're in a confined space, I probably would. It's up to you, though. If you're cool, catching the flu, catching the cold, it's up to you, Suck it in, right? So evaluate, so wear the proper PPE is what I'm saying. So if you have a patient that you think this is a contagious respiratory illness, I'm going to go ahead and put the mask on. Zika virus, right? That's out there, right? Zika virus is an STD.
Oh, yeah.
Mm-hmm. It's a sexually transmitted disease. I don't know why I just threw that in there, but most people think a mosquito bite is a mosquito bite and is limited to who? The victim herself. It could be sexually transmitted. So that means it could be transferred from one person to the next. So a lot of these diseases, especially respiratory, it's airborne. It could be transferred from one person to the next, all right, via airborne. All right, so evaluate oxygen concentration, carbon monoxide. If it's a carbon monoxide situation, that's patient has difficulty breathing. Carbon monoxide is not biased. He's not going to say, oh my God, you're the paramedic. Okay, don't worry, you can inhale. I'm not going to go inside you. It doesn't happen, okay? So if you enter an environment that's carbon monoxide, before you enter, have respiratory protection or vent the place out if you can. All right, gases, a lot of gases are irritant. They can irritate that patient's respiratory tract. I will tell you, a lot of gases, like chlorine being an example, depends once again on how much you ingested, how long you've been exposed. But a lot of times those gases could be neutralized before they even hit the alveoli. The body already neutralized it. So you can have some irritation, cause some wheezing. So how you fix that? Give the albuterol. So we give the albuterol. Now if the burning persists, then we'll consider maybe giving like sodium bicarb via nebulizer to neutralize whatever is left in there. But most of the gases are neutralized prior to getting to the alveoli. All right? So remember, highly contagious respiratory illnesses, what we're going to do? Protect yourself. How you protect yourself? What mask are you going to put on? What type of mask are you going to use? Surgical mask? N95 at the minimum. Use N100s, which are better than 95s, but they're both good enough. Who you put the N95 on? Us. Do you put it on the patient? No. Because N95s filter what type of air? The type you inhale. And it has expiratory. It don't filter expiratory air. So if you put it on the patient, you're still sucking in all the infectious disease, but you are hooking him up or her. They are breathing in filtered air, which don't matter. They're the ones who's infectious. So you can put a surgical mask on them, but the N95 goes on you. Because it's filtrating, yeah.
I don't think that the respiratory stress patient will have that.
No, probably not. No. So respiratory stress can impair ventilation, diffusion, perfusion, right, or a combination of all. All right? So pay attention to that. So we're going to size that up. We look at that. Rapid onset dyspnea can be caused by multiple things. Anything bronchial spasms, anaphylaxis, PE, or pneumothorax. All those can disrupt the flow of oxygenation that can create the patient to develop a sudden onset difficulty breathing. Okay? So we want to follow with general impression. What's important about general impression? Gives you the identification of how does my patient present to me. If I saw the patient tripoding, severe distress, and pursed lip breathing, I see he's barrel chested. What are you thinking automatically? COPD. And you got that from what? A quick general impression. So when you understand your signs are things we see, symptoms is what the patient complains of. So you can see the signs and recognize them already 2 steps ahead of the game. I know where we're going with this. So narrow chested, muscle weakness, pursed breathing, I know that's emphysema. If I see how the patient lives, sanitary area, is obese, why would they be obese and bloated and blue? Retention of water. Very good. Hacking a cough, coughing up a bunch of stuff, yakking up a lot of stuff. That's bronchitis, right? Chronic bronchitis. So get into a primary assessment, and prior to primary assessment, what we do, life threats. We look for life threats. Anything that's a life threat, we correct immediately. Right? Get into our primary assessment. We look for certain things for these cardiac patients. Are they tachypnic, diaphoresis? Are they paled or blue, right? Because they can trigger, these things can trigger tachycardia, diaphoresis, and pale can trigger by increase the work of breathing. You see the patient is breathing a lot faster. Not only are they tachypnic, they increase work of breathing. So you see the abdominal muscles, the accessory muscles working harder. What is the muscles of the neck for? What are they designed for? Hold your head up. So if I'm using them to hold my head up and to help me breathe, then I'm doing twice as much work than I should. So that means I'm going to fatigue out twice as fast than I should. So when those muscles fatigue out, what happens to breathing now? Becomes inadequate. How can I pick that up? What's the head going to be doing? Head bobbing. Because those muscles can't keep the head up no more. All right? Anxiety, hypoxia, all those things can trigger what we see right there, tachypnic, tachycardia, diaphoresis. So position and degree of distress tells us a lot. How the patient is sitting, tripod position, where they're sitting, leaning forward, that's the tripod position. Versus laying flat or laying down. Could be one or two things. Maybe they're not in that severe distress, or maybe they're quickly deteriorating that they're able to lay down. Okay? So head bobbing, we just talked about that. That's pretty obvious, all right, that the breathing has become inadequate. All right. Breathing alternation or alternation can be something that's problems with the airway branches. Maybe the bronchioles are constricted. Maybe the bronchioles are spazzed. What spazzed the bronchus? What caused constriction? All right. Maybe at the alveoli, we're having some issues exchanging gases. The question is why? What took place? Problems with muscles and nerves. Okay, did something happen initially, like a trauma or traumatic event, or do they have a neurological disease that's creating this issue? And where we get all this information from? Where are we going to pick up on all this information? Know that this is a problem. Assessment. Assessment. If you don't do an assessment or a good assessment, we're going to have a problem. All right? Or we're going to have poor assessment, is going to lead to poor treatment. We're going to think it's something that's going on and something totally opposite because we didn't do a good assessment. All right, problems with rigid structure of the chest. When the chest is rigid or the muscles are not as pliable, what's going to happen to the adequacy of chest rise? It's going to decrease. So now we have problems there. All right, it can alter your breathing. So increased work of breathing, patients usually use accessory muscles that we talked about, whether it be the neck or abdominal muscle, intercostal muscles. In children, you'll see it more. The sternum, the bones are so pliable that you can see that sternum will just retract. You can be like, holy cow, it looks like somebody's compressing on that chest. I mean, it really sunks in. It's going to sink in, I should say. Okay? So you can see that kid right now. You can see how his chest is sunk in. All right, and then you see seesaw breathing. Stomach comes out, chest goes in, chest goes out, stomach comes in. You'll see a lot of that. All right, the profound intrathoracic pressure changes, all right, and can cause peripheral pulses to weaken or even disappear. And we want to talk about, pulses, paradoxus, and stuff like that. If you're taking a blood pressure, you see it stops when you're taking a deep breath, or it drops. Okay. We're going to look at the depth to respiration. All right, patient with adequate rate but low volume will have inadequate breathing. Meaning, I'm breathing 15 times a minute, 12 times a minute, but my adequate chest rise is not significant. It's not enough. So my breathing is inadequate. What will cause that? So rate to be fast or normal, but my tidal volume, how much I'm sucking in, is not enough. Okay, Nemo? But the kids, Nemo could do that. What was that? No, not so much asthma. I mean, it could. I shouldn't say not so much, but I'm referring to more of quickly notifying or identifying that it would be a flared chest. Flared chest is not going to allow the chest to what? Expand adequately. So my rate might be good, but my tidal volume is not. All right, then we go inspiratory to expiratory ratio. The ratio should be a 1 to 2. 1 second, inhale. And approximately 2 seconds to exhale. Why inhale is less than exhale? Why I can inhale a lot quicker than exhale? No. The diaphragm is moving. The diaphragm is actively moving. Very good. So it's pulling down. So I suck air quick. But when I exhale, what's my diaphragm doing? Just relaxing. So it's going back to its normal state. So it can take up to 2 seconds. So 1 to 2 is a good ratio. It's not bad. It's perfect. Is when we start seeing those ratios change. 1 to 4, 2 to 6. What's that telling you? I'm struggling to do what? When I got a 1 to 6. Say it again. Exhale. So I have a prolonged expiratory phase. That is classic for asthma. You'll see they make this. And they struggle. It takes so much longer. That's classic in asthma. Because what's going on? Bronchial spasm. So they're having a lot of problem getting the air out. So what, if it really prolongs, who's going to participate to push that air out? Who's going to help diaphragm out? Abdominal muscles. They start pushing that diaphragm up so it can get that air out. All right? So we listen to lung sounds. We should auscultate. All right, when we auscultate for lung sounds, not only do we listen press right versus left, we want to make sure we got symmetrical chest rise, meaning that the right and the left side are expanding equally. That is not like this. All right, it should be equal expansion. All right, so some conditions are gravity dependent. All right, so we know that. So how they're laying down versus sitting up could be of a difference. Somebody who's having severe distress, they shouldn't want to lay down, because it can make matters worse. But if they do lay down and they don't fight you on that, what's that telling you? They're starting to deteriorate. They tire out. Very good. I used to have some patients up north. I worked in New York. And we didn't have sedation. We weren't allowed to sedate patients to intubate them. We weren't allowed to. We never got permission to. So I had patients who breathing was going in, and I had patients actually did this to us. You know what they're telling us? Tube them. And one of my partners will hold them down, or one of us is putting it in there, forcing the tube while they, and just so we can get it in. Because once we bypass the gag and we got that tube, and it had to be quick, and watching the vocal cords open and close, make sure when they open, we pass the tube. That's what I do. Once we got a tube and we ventilate for them, they felt better. Because what were we doing? Physically pushing that diaphragm down, making gas exchange take place. Obviously now we can sedate, but back then we couldn't. That's what we used to do a lot of times. And you had to be quick. Why? We don't want to keep stimulating that gag and make them what? Vomit. All right. All right. So we're going to talk about these. We're going to show you these after lunch, but the different breathing patterns. All right. And what to hear, ventitious lung sounds versus abnormal. Listen, if you hear lung sounds, wheezing, rhonchi, rails, I don't care what the sound is, not regular, and is in one location, everywhere else is clear, what are you thinking? Just here. Everywhere else is clear. Pneumonia. Pneumonia is isolated. It's going to be an isolated sound. How about if I have rhonchi here and rhonchi here, everywhere else is clear? What we have? It's pneumonia too. It's just what? Both lungs, bilateral. Right? They're called double pneumonia, bilateral pneumonia. Everywhere else is clear. But if I hear wheezing all over, what are you thinking? Asthma. Or it could be COPD. If I hear a lot of rhonchi and junk all over, what could it be? No, it's all over. Could be chronic bronchitis. It could be chronic bronchitis, they go wheeze as well. So if I know they could wheeze or have bronchi, how you know is that bronchitis? History. History. You got history of COPD. Well, guess what this probably is? COPD. Looks like a duck, walk like a duck, act like a duck. It's not a chicken. Right? All right. So some conditions cause abnormal breathing to hear. Sometimes you could hear it. You walk in, and you hear the wheezing, or you hear the rails, you hear the bronchi. When you walk in, it's audible. I know people like panic. That's not good. But you know what? I can hear it. If I can hear it, what's happening? I'm exchanging gases. Ventilation is taking place. We're good. All right? So when you hear the sounds moving better through fluid than in air, you know, like our pulmonary edema will have something like that. All right, you want to listen to the quality of the sound depending on how much tissue between the scope, meaning are you listening through a lot of fat or a lot of muscle? Where's the best place to listen, the front or the back? To minimize the fat and muscle, the back. Do we always have that luxury? No. But if you do, that's where I want to listen. Bring the shoulder blades in. Why? Open up the back and then listen. Okay? That's where you get the best sound. So wheezing could be, we know wheezing deals with more asthma, it could be COPD. If it's localized to one area, it could be pneumonia. Crackles, you can hear rails. Crackles and rails is the same thing. Pulmonary edema. Bronchi could be pneumonia, could be COPD, could be just bronchitis, not chronic, but just regular bronchitis. Friction rub sounds like sandpaper. Could be more of an infection between the linings of the lung. All right, like pleurisy, pleuritis, stuff like that. Stridor is up here, grunting is up here, it's all upper airway. So those are upper airway problems that you could probably fix. All right. Snoring, gargling, stridor, once again, those are all upper airway. Right? Very good. Sputum is important too. We look at sputum. So pink frosty sputum, that's congestive heart failure. Pulmonary edema, easy, done. I know what that is. Thickness of the sputum, thick stuff is probably a dehydrated patient. Guys, with asthmatic patients, you know we don't do to our patients that we should do? Hydrate them. A lot of asthmatic patients are dehydrated. Why? They don't eat. They're constantly breathing. That's unaccounted for a volume loss. When you breathe, what do you get rid of? And? Water. So if I'm breathing, if I'm tachypnic for a long time, get rid of water, unaccounted for water. I'm probably not eating right, drinking right. And when you have a dehydrated asthmatic patient, a lot of times the albuterol won't work because the plug-in is so thick. I open up the bronchus, but they're still having difficulty breathing. Because what? All that mucus. You know what? Because they dehydrated, it becomes thick. That mucus becomes thick in the alveoli, especially COPD patients. Their mucus is thick. By hydrating them, you know what that does to that mucus? Thins it out. So guess what they could do now? Get that stuff out. Sometimes you start hydrating them, and all of a sudden they cough it nonstop, and you panic. Like, oh my God, I'm making him worse. You know what you're doing? Making him better, because now he could do what? Cough that stuff out. Because you got to hydrate these patients. So when you don't see that asthmatic doing well, it's probably because they're dehydrated, and that stuff is so thick, it's not penetrating. So hydrate it, make sure they hydrate it, all right? So the yellow, brownish stuff we look at, those are odor secretions. Normally you see that in, could be could be in pneumonia patients. Clear white deal more with bronchitis or even asthma. All right, blood streaks, well, if it's bright, it could be tuberculosis. But keep in mind, if this guy's been coughing up a lot, that could scratch up the back of the airway and they could have some blood as well, okay? All right. So neurological insult, remember brain trauma can cause inadequate breathing or changing breathing patterns. Chain strokes, Shannon strokes, neurological buyouts, all that could be with head trauma. All right, so go through this chart. These are a lot of them. A lot of these deal with brain injuries. You got to know these breathing patterns, especially agonal, but that's easy. All right, we got to know agonal. I want you to know buyouts. All right, I want you to know central neurological hyperventilation. I want you to know Shannon-Stokes. All right, what does hiccups mean? You know, those are just spasm, contraction of the upper airway. Kuhl's-Miles respirations. What's tachypnic? You know, fast breathing versus slow breathing. All right, those are the ones that I need you to stay focused on. You've got to know all those. You will be tested on them, and you're going to see those in the simulation. Because if you could pick that up, that breathing pattern, then you know what the disease is. All right, same thing, and you know what the problem is. So if I see that Shannon-Stokes, I know we're dealing with lower brain, or it could be brain stem, which is right next door. So normally I would see with a patient who has insult to the brain, I will probably see neurological hyperventilation first, and then they'll quickly go into Shannon-Stokes type respiration. Later on, biots, worse, agonal. All right, so you can see that there. You can see the different breathing patterns in the location. So we got to be able to pick up on these breathing patterns so we know exactly what the issue is. So if I had a patient who had Shannon-Stokes breathing, I know that might be early on with a head injury versus now I see biots breathing. I know that's what? Later on. So I know this is a late stage. This guy's been herniating for a little bit. Okay? All right, and circulation. Circulation, notice general cyanosis versus regular. That's easy to identify. I'm cyanotic, I'm not moving good oxygen. If I'm pale, I got restricted oxygen. So cyanosis means I'm not doing good. All right? Healthy hemoglobin should be 12 to 14, all right, as cyanotics begin less than 5. So 5 grams per deciliter is not good. Look how far we are from normal, okay? Chocolate brown skin may occur from high levels of, you know, methylmyoglobin. All right, so you could, if you see that, obviously, very rarely we won't probably see a lot of that pre-hospital unless they're dealing with some type of chemicals or gases in a location, warehouse, industry, or fire, or some side effect. Pale skin just means restricted blood flow. All right, we go into the skin dry, cracked lips. That flurry tongue, sunken eyes, those are all signs of dehydration. Okay. So transport these patients immediately to the most nearest facility if you can't control it. If the patient's a pediatric, we take it to a pediatric center. If this patient is an issue because dialysis, you got to take it to a place where they could dialyze this patient. So you got to take them appropriately. If it's a trauma patient has significant trauma, they go to a trauma center.